Now we shall see the pitfalls in interpretation of structural progression by Dr. GEETA BEHERA. Over to you.
A very good evening. We'll get on with it quickly in the interest of time. So I will be speaking a little bit on the problems with assessing progression on the imaging devices. So these are the three imaging devices which we have, and I will be basically focusing on the OCT, which is the most commonly used device. So the problems with assessing progression on OCT is mainly due to these factors. It's either the floor effect, which is seen in advanced glaucoma, aging, that is RNFL loss at a rate of 0.3 to 0.5% per year, measurement variability, which is device related to the image quality, decentration error, segmentation error or clipping error, presence of local defects that can be easily missed, and cataract development. So floor effect pertains to the point at which no further structural loss can be detected. This is basically seen in advanced glaucoma, and it has to be remembered that the RNFL flows much earlier than the GC-IPL. So the average floors that are estimated are 105 microns for the BMO, 38 microns for the GC-IPLT, and 38 for the CPR-NFL. But please remember that the CPR-NFL floors much earlier than the GC-IPL. So if in floor effect in early to moderate glaucomas, progressive thinning of the RNFL is measured by imaging is very useful to judge progression, but it has very limited utility in advanced glaucoma. So in advanced glaucoma, progression can be better assessed by macular measures and imaging, that is the GC-IPLT, serial visual fields, or combined analysis of both. This has also been proved, and this is a particular study which showed that in advanced glaucoma, more GC-IPL tissue remains above the measurement floor compared to other measurements, suggesting that GC-IPL thickness is a better candidate for detecting progression. This is just a case I wanted to illustrate. As you can see here, the average RNFL thickness is 52 and 55 microns, which is almost completely floored, whereas if you look at the if you look at the GC-IPLT, you still have 65 and 67 microns. So you can follow up this patient. You can look for progression using the GC-IPLT. All right. The other option is to do 10-2 visual field testing or to do a macular field. Then the effect of aging. Now, retinal nerve fiber layer thickness loss is at a rate of 0.3 to 0.5% per year, particularly beyond the age of 40 years. Now, it has been seen that the average loss is about 0.5 micron per year beyond the age of 40 years, with the sector-wise loss being even greater, almost 1 micron per year in the superior and the inferior RNFL. And this affects the GC-IPLT more than the circumpapillary retinal nerve fiber layer thickness. So this should be kept in mind when assessing progression in a serial analysis of OCTs. Because of the effect of aging, it is now suggested that we use age-adjusted RNFL progression analysis, but unfortunately, this is not there currently in any of the devices. This is in development. Now, the next part is measurement variability. Image quality is a very important source of error. Just to illustrate a case in point, if you see, these are all the image quality of a particular patient done on the same day. And with the variation in the quality score, there's a very large variation in the average RNFL thickness. The baseline was about 93 microns, and the progression drop, that is the actual drop, is about 88 microns. But if we had not repeated it based on the quality score, we would have been stuck at 79 microns. We would have overestimated the progression greatly if we had not looked at the quality score of the patient. Now, so this has also been proved very well that this is a significant source of error even when the SSI values are within the manufacturer recommended limit. So even if the SSI is better than manufacturer recommended limit, it's still a good idea to look at the quality score when comparing it with the previous OCT. Now, measurement variability can also be due to decentration errors. Now, decentration errors are an error, a circle scan error of 0.1 mm can lead to a 2 micron error in the average RNFL thickness. Now, this is huge because the guideline for suspecting progression is 2 microns. But if your scan circle is decentered by even 0.1 mm, you're making an erroneous diagnosis. Again, just to again, another case in point, please look at this 2 scans. This patient, as you can see in the left, what you call, in the left map, there is a very large decentration, and the average RNFL thickness is about 79 microns. And when you look at the other map with 85 microns, which is a well-centered circle. The only machine which actually overcomes the decentration error is the Spectralis ST-OCT. It has a dual beam scanning system which completely eliminates the scan circle problem. The other devices, unfortunately, do not have this technology. So the another source of error is segmentation error. So what is segmentation? Segmentation is the delineation of the various layers. So if there's an error in the segmentation, that is if the segmentation is not done properly, for example, in this particular area, the segmentation line is above where actually the RNFL should be. So this will be interpreted as a relative progression here. Similarly, if the segmentation line is going above the area, this will be erroneously reported as being a better scan, but actually this is not the case. So one has to look at the actual scans here. Similarly, there's another very important source of error, which is called a clipping error. If the OCT device is too close to the patient's eye, then part of the scan is inverted and completely clipped out from the analysis. So this area is completely gone. And this shows, and on the progression and the analysis will show that there is a significant progression here as compared to the baseline. Please note that the gray line is the baseline and the black one is the current field. Local defects, again, are very, very commonly missed because local defects generally get averaged in the global metric, that is in the average RNFL scores or the global metric scores that are given. Local defect gets averaged out and they get missed. So again, it's very important to look at the actual segment. So this is the baseline, which is showing in which one can see the RNFL thickness. And this is the follow-up where actually there's a drop, and that drop is seen very well in the double hump. It's in the graph, TSNIT graph. But this will get missed out when you look at the global average. Again, this is again found to be a very important source of error, and so it is recommended that it should be a standard protocol for detecting glaucomatous progression. Cataract can also cause significant underestimation of the RNFL, much greater than what can be accounted for by the poorer quality score. As you can see here, the quality score between the two imaging time points is 6 out of 10 and 8 out of 10. So the quality score, there's about a signal strength difference of only 2. But if you look at the RNFL score, it's about almost 13 micron difference. So this can easily be misinterpreted as a progression, but after doing the cataract surgery, you see it's almost back to normal. And what you see in the other eye may also be actually due to the cataract and not due to any glaucomatous problem. Again, if a glaucoma patient actually develops cataract, this may be misinterpreted as progression, and only after the surgery is done, the baseline has to be reestablished. This cataract actually affects the GC-IPLT far more than the circumpapillary RNFL. Again, if you see, 7 out of 10 is the signal strength here, 9 out of 10 is the signal strength here, but the average thickness difference 56 micron and 64 micron. And if you look at the deviation map, you can see the huge difference in the deviation map between both the eyes. Okay. Again, cataract causes significant underestimation of RNFL, both in cirrus and stratus OCTs. So what is the best structure to measure? It is the circumpapillary RNFL and the macular GC-IPL. And about 5 micron is the significant change. But if the RNFL floors are lower, then one can use the RNFL BMO as well. And a normalized trend-based analysis, which are not available our underdevelopment is what is recommended, is what is the future, what is going to come up. I will be very briefly touching upon the HRT and NFL because there is comparatively less data on the progression analysis, and the HRT was extensively covered by Dr. Shikha. So she just showed you these maps, the baseline exam and the what you call the subsequent examinations, the trend analysis showing rate of change. Now the problems, the two problems with interpreting HRT, one is that it is dependent on an operator drawn contour line. So if this is drawn incorrectly, then you will get an inappropriate what you call interpretation. The current version uses the GPS and other parameters like the cup shape measure, which are independent of the operator drawn contour line. But again, there is no data on its utility to assess progression. That is not known yet. The NFL, the nerve fiber layer analyzer, is has a wonderful what you call progression analysis, GPA, that is a glaucoma progression analysis, which shows both pixel-wise what you call change analysis and also the trend-based analysis. This is affected by cataract progression, unfortunately. This is because the lens is a birefringent structure, so cataract affects the NFL far more than it affects imaging by other devices. Again, there is minimal data on the progression analysis related to